All right, everyone, if you want to go ahead and turn your cameras on, we're getting ready to begin the webinar. And make sure to unmute yourself. I am going to put it on the speaker view. So just remember that when you speak, you will be brought on the stage. So just a couple small items for everyone to know. If you look on the bottom right, you'll see a Q&A panel. You can ask questions directly there, and people can upvote it, and we may put them on screen. There's also a chat function on the bottom right, and you can have discussions with people in there. We have some of these cool features, and we'll go ahead and get started. Nocha, I'll let you go ahead and take the stage.
Good evening, everybody, and thank you for joining us. I know it's summer and we all have a million things to do, but this is an incredibly important topic, and I think we've got a passionate group here tonight. So I expect this conversation is going to really get going. We're here to talk about the medications that we get during our dialysis treatments, and how this is paid for in what we call the Medicare bundle, and how that's impacted by CMS regulations and congressional actions, and how we have access to some of the newer or how we can get access to some of the new medications. So we have joining us tonight Dr. Jay Wish, who is a nephrologist and somewhat passionate on this subject. Lauren Buckley is going to give us some history of how this has transpired over the years and what we need to do. And then you're probably familiar with Eric and Dawn, who they're somewhat passionate about dialysis care at home. And I think that we'll just jump in and get started. First off, Jay, I'm going to ask you a quick question about the importance of the phosphate binders for the patients. Give us a little perspective on that first.
Sure. So phosphorus is a substance that is present in just about everything that you eat. So if you're going to eat anything that comes from cells, animals, or vegetables, you're going to get a load of phosphorus because all cells are rich in phosphorus. So your body takes the phosphorus that it needs to build up its own cells and for other purposes. And whatever the body doesn't need, it gets rid of through the kidneys. So when your kidneys aren't working, like when you're on dialysis, the body has no way to get rid of it. Dialysis is not particularly effective in removing phosphorus. It removes some, but certainly not anywhere near the phosphorus that the body generates from the digestion of food that you don't need for your own purposes. And therefore, we need to look for other ways of ridding the body of phosphorus. So typically, the way that we do that is to administer what are called phosphate binders. And phosphate binders do exactly what the name suggests. They bind with the phosphorus from the food inside the GI tract and prevent it from being absorbed. And then the bound phosphorus, whatever binder is being used, is excreted in the stool. So the body doesn't get a chance to absorb it. And as a result, the serum phosphorus level will be lower than what it otherwise would have been without the phosphate binders. The problem with phosphate binders is that they're often poorly tolerated by patients. They cause constipation and bloating and a variety of other symptoms. There's a very high pill burden. Typically, a phosphate binder dose requires 3 or 4 of the phosphate binder tablets or capsules to be administered with every meal. And part of the issue is that, of course, the phosphate binders only work if they're in the GI tract at the same time as the food. So they have to be administered with the meal. And many patients travel for their meals. They eat out. They're on vacation. They don't necessarily take the phosphate binders with them. They're not handy in their pocket every time they sit down and take a meal. So as a result, the phosphate binders are often ineffective or not as effective as we would like them to be. And the serum phosphorus level remains elevated. It's estimated in the United States that approximately 60% of patients who are on dialysis have adequate phosphate control, which means that 40% do not. And I guess it's for a variety of reasons, the side effects, the pill burden, etc. So why do we worry about phosphorus? We worry about phosphorus is because it binds with calcium in the body, and the calcium phosphate salt, it's basically a crystal, deposits in the small blood vessels throughout the entire body, and that can block the circulation to a variety of organs, including the heart, the brain, the skin, etc. And it's the long-term effect of that calcium phosphorus depositing that we worry about. So the lower the phosphorus level is, the less chance it's going to bind with the calcium and the less chance you're going to get small blood vessel disease that can ultimately lead to complications, hospitalizations, and ultimately death if the organs are severely damaged by this small vessel disease.
So thank you, Jay. That's a great background. And now I'm going to switch to Lauren to bring us up to date on how these binders, are actually paid for. As a lot of us have noticed or may not notice that we get our medications through our clinics and we don't really think about it. And then on the other hand, I see where some patients are prescribed prescriptions that may not necessarily be included in their bundle. And some of those have ranges of payment that can run from like $50 copay to thousands of dollars for the same medication. So Lauren, I'm going to ask you to give us a little background on how we actually get these medications as patients and how they're paid for and what we can do about that.
Sure. So under Medicare, these oral-only drugs are currently covered under Medicare Part D, which is the retail pharmacy benefit, or under other insurers outside of Medicare would be through the pharmacy benefit. And so they're picked up at the pharmacy counter and are not part of the bundle, as we refer to it, which is formally the end-stage renal disease prospective payment system, which is how Medicare pays for renal dialysis items and services that patients receive. So today, these drugs are not part of that bundle, and that is because at the time that the ESRD PPS or bundle payment system was put into effect, over a decade ago, Congress chose over and over again to delay inclusion of oral-only drugs under the bundled payment system. That delay is coming up on a change starting January 1st, 2025, where CMS is planning to move forward with moving these oral-only therapies from the retail pharmacy and putting them into the bundle. And what that means from a technical perspective is that the ESRD PPS or the bundle, the way that works is that there is a set payment rate that is a bundled lump sum payment rate every time a beneficiary with ESRD receives dialysis at a dialysis session. And there's a dollar amount set for that every year. And that dollar amount has to cover all renal dialysis items and services that the patient receives. And while bundles can be convenient, they provide a transparent payment rate. They do have financial constraints on providers that are making decisions for the items and services to be used and paid for under that bundle. And I think that that's the concern with phosphate lowering oral therapies moving into the bundle is that these bundles are not necessarily meant to incorporate new and innovative items and services, and there can be access challenges posed the more and more you try to draw in different items and services under a system that already does have, kind of a cap set to it.
So absolutely, this is something that is really hard to understand, and it makes the choices that patients have depending on what clinic you have. But that bundle has a very small profit margin for the clinics. Basically every dialysis treatment is paid at, just throwing out $250 per treatment, and everything that you need, it has to be covered under that payment. And so consequently, the clinics are always going to look for a way to lower those costs, and which means that including in an oral only, into the bundle, a new drug that's going to have a higher cost or, be more prolific is going to be a lot harder to get a hold of. And so this is why it's really important for patients to understand the importance of keeping our medications, as much as possible under our control and not necessarily under the bundle payment. So taking that aside, let's hear from Dawn, who is a patient and has needed some binders over the years, and how this is going to affect her. And then we'll hear from Derek. Eric, sorry.
Hi, everyone. And Neilcha, thanks so much for inviting me to share with you all this evening. We as patients, we need to be in as much control as possible over our healthcare and well-being. These drugs going under the bundle can have a huge effect on the amount of control that we have over the medications that we're taking. My main concern is that I'm currently taking 2 phosphate binders right now. And if our medications go under the bundle, that could mean, just like you said earlier, Neelcha, that our provider is going to try to save as much money as possible. So instead of me being able to take 2 phosphate binders, which could be pretty costly to my provider, I could be prescribed something like Tums, which is something which is cheap that I could buy over the counter, which may not give me the kind of effects that I'm looking for or the type of phosphate binding control that I want. So, as an empowered patient, I'm going to push back on my provider and I'm going to let them know that this is not the desired form of treatment that would be best for me. And I want the type of medication that I want. I want to sit down and have a conversation with my provider, with my doctor, and I want to be able to decide with my doctor which is the best binder or the best phosphate controlling medication for me. And that's what I advise the rest of us as empowered patients to do. Sit down and have these talks with your doctor. Look at your numbers, which is really important. You should be looking at your numbers monthly, and if your phosphate binding medication or any other medication is not working well for you, you should be having these important talks with your healthcare team.
So have either of you, Eric or Dawn, had an experience where your physician has prescribed a certain or specific medication, like a more costly binder that works better for you, and then have it denied by either your clinic, or in one case, the person asks what happens when your insurance company denies. Ironically, you have more choice when the insurance company denies your payment because you can appeal. The bundle doesn't necessarily have an appeal process for patients. But Eric, what are you thoughts? Oh, you mute. Take off.
I was going to kick it to Dawn because I know she has an answer to that specific question. I'm happy to talk about a lot of other things, but I know Dawn has this answer.
All right, Dawn.
Yeah, I sure do have an answer. We had this similar problem with the ESAs or our Epogen or Mycera or Retacrit or some of the other ESAs that we take. I changed providers recently, and when I changed providers, I had to go to bat for myself because the clinic that I was at was using another type. I don't want to get into the names of the drugs, but they were using another type of ESA that I had not been previously taking. And I sat down, like I said, as an empowered patient, and I had that talk with my care team about a medication I had been taking for over 15 years. And I did not want to change to a cheaper drug. And we did have that conversation, and I was able to continue to take the medication that had been working best for me. So, as I said, you have to have these conversations because, of course, it's in the bundle and they want to use what is most economically beneficial to themselves. But you as a patient can speak up for yourself and you can request to change to a medication that either works better for you or is going to give you, like I said, the best results.
So I could add to that, Neelcha, and actually it's based on phosphorus binders. And just a number of years ago, there was another binder that came out that was novel at the time, meaning it was brand new, and it was iron-based. I have a disease called porphyria cutanea tarda, and one of the problems with porphyria cutanea tarda is if you have too much iron, you get these really big blisters that are deep in your hands and takes a long time to heal and can become infected. So I needed to be able to find iron in a way that wasn't a big bolus at a dialysis center. or even if I were to inject it at home. And I found this iron base, and then I realized I had too much diarrhea with that specific. But then I worked with my physician to basically balance it with a calcium base. And so I think it's important. I think Dawn already mentioned this. I see myself, and we should all see ourselves as captains of our own health, right? And to me, my physician, and I've been blessed with two really good ones over the last 23 years. That's the amount of time I've been on dialysis, which has mostly been on home. Is they need to be the number one. They need to have access to all tools, new tools, as well as those tools that have learned to perform or shown the performance and something we want to rely on. And without that access to the new tools, I am not going to get my best outcome. And for me, best outcome, and for all of us, our best outcome needs to be healthy. And also, let's not forget about mortality risk. We want our mortality risk low, right? We want it low, especially for those of you here that are on home dialysis. We're already making these choices, advocating for ourselves to get the best outcomes that we possibly can with our physician. So when we put things in the bundle, and we're curtailed potentially from things we don't even know which may be coming down the pike, our best interests are no longer at hand. Now we're part of an economic puzzle, and that's not how we get our best outcome.
No, absolutely. Lauren, I wonder if you could just give us a little more information on what CMS, which is Medicare, which is taking care of pays our dialysis bundle premiums, no, not premiums, but the actual cost. So what are they actually doing with these oral only drugs? And what do you think we as patients can continue to do or start doing that might help keep the choice in where it should be, which is with us?
Sure, I can definitely talk about that. So the Centers for Medicare and Medicaid Services, which administers Medicare, they update the end-stage renal disease prospective payment system every year. And usually it happens over the summer. So what happens is they put out what's called a proposed rule, and that has changes that they're looking to make, that they're thinking about doing for the upcoming year. And they open up what's called a public comment period. And that is a 60-day opportunity for anyone, patients, providers, members of the industry, anybody at all who would like to weigh in. There is a way to go on to the regulations website and to put in a comment. And this can be anywhere from, a comment that's written in the comment box to much longer memos that they get with comments that are submitted as longer letters. And they take these into account. They are required to read all of the comments that they receive, and then they put out in the fall what's called a final rule, and then that goes into effect for the next year. So where we are kind of right now and the urgency that's happening today is that we're in the midst of that public comment period that goes through August 25th. And so for those of you that are interested in weighing in related to keeping oral only drugs out of the bundle, this is an opportunity to do that. CMS said in last year's rule, so in 2022, they said we are going to do this in 2025. And they were silent on the issue this year, meaning that they are moving ahead with that absent having their mind changed. And so this is really that opportunity for those who do want to be active on this issue to weigh in with CMS through the comment process. And, we are still another rule cycle out from 2025. So I think this is prime time for them to really hear about this as they are thinking about what the bundle is going to look like in 2025. And there are things happening in Congress I can talk about too when we get to that point.
So I'm going to jump in here because this is really an important point. Every year, right around the July 4th, the comment period comes out with the proposed rule, which is part of what we're talking about here. This bundle for the oral only drugs is part of this year's proposed rule. And HDU has made it a policy since I've been on board for over 10 years to always comment and represent you. And if many of you know me for many years and watched me with my tirades, on our Facebook pages, where I talk about how impactful we can be when we have a voice. And we have a really strong voice. And in the past, we've been able to accomplish things. One year we wanted to add new an extra payment for new devices, which was things like getting the Tableau, an extra payment so that it could be incorporated. We want to make sure that this new technology reaches the patient. So we worked on the TEPNIs and getting it approved. And we have a system where we will send out over the next month links that will have where you can sign on and support our efforts. This, I cannot begin to emphasize how important this is to our efforts, to you, because you can make these changes. If we hear from enough patients out there and your families and the people that support you that you want these changes, CMS will listen. I promise you, I have seen them do it over and over. You know, not just with the TEPNIs. We did it one year. I wrote a comment to CMS on their proposed rule, and the next year they actually had me speak at their conference. And these things are important, so you know they're reading it. They have to read every single comment that comes through. So I cannot begin to stress, you know, and I do this every year, and I know I'm sound like a broken record, but if I can have you leave with one thing tonight, it's that your voice counts. We need that voice. We need you to support. If you know this is something that you believe in, we need you to support this. We're going to provide you the tools. We've got a link tonight. It will be in the chat. We'll also have it sent to you by email. It'll be on all of our Facebook pages. And for the next 25 days, we're going to be launching a campaign to make sure that your voice is heard on this issue. And, you know, if it goes like it has in the past, we might be able to affect change. And you should be proud of that. That means that we do have a voice. You know, we have such a little voice in so many things that happens to us with our dialysis and our treatments, but you have a voice here. And I cannot say enough that you have to use it. So I'm sorry, but let's jump back in here. Dawn is shaking her head. I know she's been avid with this, and Eric, go ahead and speak up.
Oh, yeah, sure. Nilcha, I'm right with you. As a member of the Patient Advisory Council for the Forum of ESRD Network,
Yep.
we also exercise our voice, and we write responses when the proposed rule comes out. You can also do it through the National Kidney Foundation. They're looking for groups right now to forming groups for you to speak up, for you to speak back to CMS, you know, and there are so many other patient advocacy groups. AAKP does it. We all respond when
Yes.
these proposed rules come out. So just look for it. It's out there. And I just beg of you, we don't have to accept what's being given to us. We do have voices. We're patients. We're paying where we want what we want, and we have the right to speak up. So please don't just sit back and accept what's given to you. I say that to my patients from Brooklyn all the way to California. Speak up.
Please do.
I just was going to add is I know Lauren's going to get into this later, but in addition to the commenting of the rules, it is also, you know, writing our legislators, visiting our legislators. I mean, I know Dawn and Nilja and I, we have seen so many things change. And I've been in policy for a number of years with watersheds and wetlands before this, but then also with kidney disease for about 23 years. And when I sat in the room with the previous president to sign the executive order that launched these rapid increases in targets for getting folks home, something I'd already known at the time for 10 years. I never thought I'd see that, but that after working with NKF and going to Congress every year, asking for a variety of things, it came through. And many of you may actually be on home dialysis now because of that executive order. You may not have even had known about it. And so our voices work, just to reflect on what Dawn and Nilja have said. I mean, we're not just saying this, we've seen it. And many of you have too, because you've been there along the way.
And Lauren, I think if there's been some recent movement, like within the last day or two, with some legislation, and then of course we have a link which will help you up to a portal where we have a comment letter that you can sign as patients you can sign on to. So if you want to go into a little more detail about that.
Sure. So there have been some exciting updates. There is a bill that has actually been introduced into Congress. It has a number. It's HR 5074, and it is called the Kidney Patient Access to Technologically Innovative and Essential Nephrology Treatments Act of 2023. The simpler name is Kidney Patient Act of 2023. And it would essentially do what we've been talking about on this call. So it would delay inclusion of oral-only phosphate-lowering therapies until the earlier of January 1, 2033, or until the time where there is an IV alternative that becomes available. And if you are active with members of Congress, I can tell you this was led by Rep. Buddy Carter, and then it has been co-sponsored just in the past couple of days by Representative Ann Custer, Representative Carol Miller, and Representative Terry Sewell. So I'm sure there will be other sponsors that will be added now that it's been officially introduced and is available on congress.gov. So there are two opportunities to weigh in, both with CMS, because they do have the authority to make this change through the way that they have interpreted the statute. And there have been these delays in the past, and then also for Congress to move forward with this piece of legislation. I think you might be on mute.
You're on.
So if we can put the bill number again, but we will make sure that that's available to you in follow-up emails, and you'll have all the information you need to act. We make it super simple for you. Again, by notifying your congressman, there's a lot of different ways, but we utilize platforms so that we can, you can go in, you put in your zip code, it tells us which your representatives, and you sign it, and the letter goes to your congressional reps. So don't worry if you don't get it off of here tonight. It's up on the screen right now, because we'll make sure that it is available literally daily for the next 25 days till the comment period is closed. I want to go back to Jay for a minute, because again, I know you're just as passionate. But do you have any insight as to how, again, these bundle medications impact both the patient and the clinics? Because you're working on basically both sides of the fence, and I'd love to get a little more perspective about that.
Sure. Just to comment on Lauren's message about the legislative fix, if you will, on the bundle payment. The original inclusion of the orals into the bundle was actually scheduled to occur in 2014. And that can was kicked down the road a number of times now till 2025, because the federal government, meaning the Congress, realized that by doing so each time, it would save the federal government approximately $2 billion per year. And that $2 billion fine was very, very tempting for them to continue to pass the legislation delaying the inclusion of these items into the bundle, because they could use those $2 billion for other spending priorities. So this is something that I think Congress will be very interested in considering, because it does, in fact, save the federal government money, and they will override what CMS does. I mean, the legislative fix is the final fix. If they say these things won't go into the bundle until 2030 something, then that becomes the law of the land, and that is definitely a much better fix, as far as I'm concerned, than having Medicare reconsider it for a year or two at a time. So this is something I think would be a very effective route in terms of delaying the inclusion of these agents in the bundle. So suppose they get in the bundle. There's a bunch of things that I think need to be considered. Number one is that it means that the bundle payment will be adjusted upwards for the dialysis provider to include the average per patient per treatment cost of these drugs. So what does that mean? It means that if you're getting 3 treatments a week, as most in-center dialysis patients get, then what they do is they figure out what the entire cost of the phosphate binders is over the course of the week, and then they divide that into 3 equal payments that the provider will get with each dialysis. Okay, now this is average cost. It means that you've got all the different phosphate binders, some of which are more expensive than others, and they're supposed to be able to figure out who's using what and how frequently and how many pills and how much it costs, and then calculate all of that and then make an adjustment in the bundle. Whether that is a fair increase in the bundle, I think remains to be seen. And by past experience, it isn't. And the reason it isn't is because the bookkeeping on what all these things cost is really crummy. So if they're not counting every single penny that's being spent on phosphate binders, they're going to underestimate the allowance of what's needed to include the phosphate binders in the bundle. And therefore, the payment is going to underpay the dialysis providers in terms of the phosphate binders that the patients are taking now, never mind any innovations in phosphate lowering therapy that may occur down the road that may increase the cost of that particular part of the patient's care. So I think the most likely scenario is that the allowance in the bundle will probably not adequately cover the current phosphate binder costs and will definitely not cover future phosphate binder costs, assuming that we all hope there's innovation in this space. And as a result, there will be pressure on the part of the dialysis providers to restrain the cost of phosphate binders, move patients to less expensive drugs, and perhaps to drugs that are not as safe. And I'm thinking in particular, the calcium-containing phosphate binders. Yeah. And if you remember what I said at the beginning of the hour, the whole idea of reducing the serum phosphorus level is to decrease that precipitation of calcium and phosphorus in the small vessels. So if on the one hand, you're giving a patient a calcium-containing binder, which will often raise the serum calcium level at the same time that it decreases the phosphorus level, then you're really not decreasing the tendency for calcium and phosphate to come together in the small vessels, and you're probably not going to be reducing the risk of small vessel organ damage. And this has already been recognized by the international guidelines on phosphate binder therapy, which specifically recommend avoiding calcium-containing binders. But the appeal of calcium-containing binders is that they're the least expensive. So for patients who have out-of-pocket costs and they can't afford the co-pays or the deductibles on the more expensive phosphate binders, that is what they tend to gravitate to. And my concern is if you throw all these phosphate binders in the bundle, then that will be the default option. And everybody will be started on a calcium-containing binder, and only if their serum calcium starts to go up will they be switched to another binder. And my concern is that that damage in terms of the small vessel disease may occur even before the serum calcium level starts to go up. I have one other comment, and I would certainly welcome Lauren to chime in on this, and that's the fact that this whole bundle payment thing only applies to traditional Medicare and does not necessarily apply to Medicare Advantage. Patients who are on dialysis who have Medicare Advantage, their payment system is a little different from what it is. And there's a lot of things that are not included in a Medicare Advantage bundle that are included in the traditional Medicare bundle, and how that affects phosphate binders if they are in fact drawn to the bundle. I couldn't explain to you, and maybe Lauren can fill that in.
So I think if the phosphate lowering therapies do go into the bundle and then in Medicare Advantage, I think one of the things that we have heard can be one of the biggest access challenges is the TDAPA add-on payment that is supposed to be provided to help pay for therapies as they transition into the bundle if they meet the TDAPA criteria, is that requires redoing all of the Medicare Advantage contracts and making sure that TDAPA payment is provided, and it's a time-limited payment, and so that does not often happen. And then there are access challenges even where there are these kind of innovative structures set up that are supposed to help bring in new products because they are short and time-limited. And I've heard a lot of challenges that folks have faced with the transition into Medicare Advantage. So I think there would be the same sort of challenges here, even though that payment system is very different.
Nilja, can I just go back to Dr. Wish for one moment, what you had just said about, calcium phosphorus binders. I mean, also when we have a higher calcium, that affects our parathyroid hormone, right? And so then we start chasing the PTH with Sensipar and calcitriol, and doesn't it just, it's part of that vicious loop. So even if we were to So, I mean, controlling one affects actually some major other systems going on with us. And I just wondered if, you would like to just speak to that as far as what you were talking about.
Oh, you're absolutely right. I mean, treating the phosphorus level, the calcium level, and the pH level is sometimes like playing whack-a-mole. You get one down with your little mallet, and then the other one pops up. Now, they are all interrelated, and the goal is to get them all into the target range that has been shown epidemiologically to be associated with the best patient outcomes. But only 30% of dialysis patients in the United States have all three levels within the target range. That's only 1 in 3. So despite the best efforts of agents that are now either in the bundle or not in the bundle, and how they're paid for, and patient decision making that's informed ideally, we're really not doing a very, very great job in our whack-a-moling these things that are popping up. So you mentioned PTH. PTH is bad for bones. We try to get the PTH level down, and we usually start that with vitamin D analogs like calcitriol or Hectorol or Zemplar. You may be familiar with some of these agents, but this downside of all of these agents that are vitamin D based to reduce PTH is that they raise both calcium and phosphorus. So on the one hand, you may be protecting the bones, but on the other hand, you may be putting the small blood vessels at risk. So there's a new class of agents that decrease the PTH level called calcimimetics, and that includes things like Sensipar and etelcalcetide. And those are becoming more and more popular, but they're a lot more expensive than the vitamin D analogs. And as a result, most dialysis providers only allow them to be used if the vitamin D based agents fail, either because they can't get the PTH down to the target range or they're causing more high blood calcium levels.
Nilcha, you're on mute.
There was a question in the chat where we don't provide medical advice here, but one of our members talked about K2 was helping does it decrease calcium deposits as recommended when taking vitamin D. So I was just curious, Jay, what's your thought on that? I've not heard this one before. And K2 is a supplement, so we're always a little cautious about adding supplements without checking with our
I'm not sure what K2 is. I'm not familiar with it.
It's a vitamin, I know I've seen it in my vitamins, but
okay.
I'm not
it's vitamin K.
Yeah.
So vitamin K, it helps your blood clot better. I'm not sure that would be a good idea for people who are on dialysis who have a higher risk of blood clotting of their access and of their,
right.
Pulmonary emboli and things like that. So I would definitely recommend against using K2, except under the supervision of your nephrologist, and make sure that you're not putting yourself at increased risk for blood clot formation.
Okay. So
I just wanted to jump into Nilcha. I saw a question in the chat, and somebody asked, was Velphoro a good binder? And I just wanted to say to patients, any binder that's controlling your phosphorus levels is a good binder. We're all different. So we have to remember every patient is different and every medication is going to work differently. So what might be good for you may not be good for me. So again, I would always say work with your care team, look at your blood levels on a monthly basis, and sit down and talk with your physician as well as your dietitian, because your diet, remember, things that we put in your mouth directly affect how you feel on the outside. So just want to address that.
Yes, and I want to echo that. What nephrologists always say is the best phosphate binder is the one the patient will take. If you don't take it, it's not going to work. And different binders have different side effect profiles, and they also have different pill burdens. So something like Velphoro or lanthanum carbonate are big pills that you have to chew. And even though the pill burden is less, a lot of patients don't like the chalky feeling of the chewed up tablet, and they say that that's not for me. On the other hand, you have something like sevelamer, which is a very effective phosphate binder if given in the proper dose, does not raise the serum calcium level, but 50% of patients will complain of bloating and constipation. So that's a limiting factor for that. So as Dawn said, the best one is the one that works for you because you'll take it because it produces the minimum side effects, and you don't have to either choose between the pill burden or the chalky chewed up feeling or whatever. Everybody has a different preference profile.
You know, and here's just when we're talking about phosphorus, here's one other interesting fact that we've learned at conferences over the last few years, and that is that the medications that are given to for the majority of dialysis patients, not just for phosphorus, can actually raise your phosphorus content. One of these is Benadryl. I mean, patients are often given Benadryl routinely during treatment, and that has the highest content of phosphorus. It actually, a dose of Benadryl has your entire daily allowance. So you want to be really careful about the medications you're taking. Obviously, you need to take them if they've been prescribed for you, but you want to also see how they're going to interact to impact your phosphorus levels, because in some cases you may not be able to control that. So, I mean, a lot of detail here. It's a very complicated issue, but the most important thing tonight that we want you to come away with is what can we do to help ourselves to be more proactive, to make sure that we get the medications that we want. And so that's why we are here. We're excited about some of the opportunities that are facing us with this new legislation. But again, I have to reiterate that we need your help. So the more of you that are going to help take action, spread the word, that better off we're all going to be in being able to have that choice down the road. So let's see. Any other comments?
Yeah, Neil, I was just going to bring up pharmacy versus clinic,
Yeah.
and availability, and how it could be more difficult in rural settings. But for me right now, when something is not in the bundle and there's remember I'm at home dialysis, which a number of our listeners and watchers are, it's easier for me to go to a neighborhood pharmacy to make a change midstream than to make it to a dialysis center to pick up a bundle, or even to wait for that medicine to become available through the clinic. So that's helpful. But I do have a neighborhood pharmacy. And I know not everyone has access to that, but so just that rings a bell for me.
Absolutely. And I'm also constantly surprised in reading through our members on our Facebook pages, the variety of payments. Something they may pay. One may pay a $10 copay for I'm just throwing several of them are out, but and I'm not saying for sure. And another one pays $1,000, and there's no rhyme or reason. So it's really, again, important to understand. And I would also encourage, if you're having these issues and trying to get particularly a binder cover that works for you, to go back to the manufacturer. And sometimes they have subsidy programs that can help support getting that drug at a reasonable price for you. So we should not just sit back and accept what is being done. We have to always question and take charge, ask those questions, go back to the clinic, go back to your physician, go back to your the drug manufacturer if that's applicable here. But seriously, our lives do depend on our ability to take charge of our health. I mean, I can't reiterate that enough. And I know Dawn and Eric both have just been through situations where that's can prove that. And this is just one example of being able to take charge and make sure that you get the medication that you need. I mean, Jay's as a nephrologist has shown us how important it is. And Lauren has, shown us that we do have a voice, and we will, as I said, continue to make these access to these support pages where you can sign on for action items, what we call call to action, and we'll have the next month for that. So you'll continue to be hearing from us, and we hope that you'll support everything. And I'm just curious, any more questions from the audience? One person has just asked if he can reach out to members of the panel after the webinar. And if you send an email to HDU, I'll just put info, put that in the chat. We'll make sure that we try to connect you. Or if you have a question here.
I make a comment about vitamin K2. I just looked it up
Yeah.
in my little drug directory. So
Please
it looks
do.
like most of the vitamin K2 preparations that are available in the United States come in combination with vitamin D to improve bone health. It actually helps put calcium in the bone, and then the vitamin D helps absorb more calcium from the GI tract so that you can put that calcium and make your bones more dense and decrease the osteoporosis. But that's exactly what we're trying to avoid in patients on dialysis, which would be the vitamin D that would raise the calcium level. So that's why I probably wasn't familiar with vitamin K2, because I don't know if it's available as a single agent. If it is, then I guess it might have some theoretical benefits to lower calcium by putting it into bone. But if it's coming always in combination with vitamin D, then you have to balance that against the increased calcium coming into the system, which may actually not be good, because some of that may end up in the small vessels.
And again, always check with your clinical team, your nephrologist, on any supplement, medication, or question that you have.
And I just wanted to throw something out too, because I do a lot of advocating and I spend a lot of time in dialysis centers talking to dialysis patients. And if we just have a minute, I just wanted to pose to Dr. Wish and Lauren as well. I've talked to so many patients who tell me that they just don't even bother to take their binders. And it just, it makes me, it makes me so passionate, because we're advocating for patients to speak up and for patients to get involved in their health care. And I know that phosphate binders, the pill burden is enormous. And it's just a pain in the neck. Sometimes I'm sitting down and I'm about to have this really great meal, and I say, oh, darn it, now I got to get up and go and get my binders. And, sometimes you're just pressed to say, forget about it. But could you just kind of give us just a little quick example of why it's so important for us to take those binders and why those pills are essential? And if you have trouble getting your pills, maybe Lauren can speak to this, how we can go about talking to our care team about helping us to get our meds.
Well, I'll start with saying that there's unassailable epidemiologic evidence among dialysis patients in the United States in particular, but actually in other parts of the world, that there's a direct correlation between the serum phosphorus level and cardiovascular events and mortality. The higher your phosphorus level is, the more likely you are to get a stroke or a heart attack or a hospitalization for heart failure. There's no question about it. Okay, so the lower your serum phosphorus level is, the lower your risk. Now, the other question is, well, if you have a high phosphorus level, what are the data that show that you in fact lower your risk of those events by taking your phosphate binders and bringing your serum phosphorus down? And I have to admit that the data for that is not quite as compelling. The data that we have has not been able to demonstrate a decreased frequency of cardiovascular events. But what it does show, and it's very impressive because it's turned up in more than one study, in when they look at the use of phosphate binders on coronary calcification using coronary scan technology, where you can actually tell how much calcium is in the coronary arteries, which is a predictor of heart attack. It doesn't necessarily correlate with actual heart attacks. It's unassailable data that shows that the more you bring your phosphorus down, the less coronary calcification you have, and you can actually reverse coronary calcification. You can actually take patients who have not been treated with phosphate binders when they start on dialysis. You do baseline coronary calcium studies on them, and then you treat them with phosphate binders, and their serum phosphorus goes down, and you do a follow-up scan 6 or 12 months later, and the amount of calcium in the coronary arteries goes down. So if that were me, that would be pretty compelling evidence that, this risk that I'm going to probably have of having a heart attack because my coronary arteries are filling up with calcium is going down because that calcium is going away because of the phosphate lowering.
Wow. That's
Dawn?
awesome.
You had a question or you want to make a statement? You had your hand up a while back.
Oh, no, I was a boo-boo.
So now we can talk again a little bit more about, I think there's something wrong with my
No,
internet.
you have a little echo.
Okay. I was just talking about how do we know which binders? I mean, how many binders are there out there, and what are some of the new ones that are coming down the pike? Jay, I hate to put the burden back on you, but I think it's really important we know what our choices are, what's coming, and especially why we want to make sure that these new drugs that we have an option to try them, especially for those of us who say have tried several and nothing's working.
Okay. So there's a long history of phosphate binders that goes back to the 1960s when people first realized that high phosphorus levels were bad for dialysis patients. The original phosphate binder was actually aluminum containing compound, like aluminum hydroxide. If you've been on dialysis a long time, you probably remember aluminum. And you also remember that aluminum was pretty much banned as a phosphate binder because it was realized that over the years, exposure to aluminum actually led to accumulation of aluminum in the brain and made you demented. And that's not a good thing. So aluminum was eliminated. Then came calcium. That was the second line phosphate binder. And the nice thing about calcium was, number one, we know that it likes phosphorus because that's what bone is made out of. And number two, it's cheap. It's out there. It's calcium carbonate, Tums, and there's a lot of relatively inexpensive calcium containing compounds. But like aluminum, a lot of that calcium is absorbed. And as I said before, ends up getting into the system. So you may be trading a higher calcium level for a lower phosphorus level. So you don't have a net sum gain in terms of your risk of calcification of small vessels. I think the big breakthrough in terms of phosphate binder technology came with sevelamer. That's Renagel, okay? Because that's the first one that didn't use a metal. Okay, aluminum is a metal, calcium is a metal. Some of the ones that we'll talk about in a few minutes are metal, like lanthanum and iron. And the problem with almost all these metals is that some of it is absorbed and gets into the system and cause problems that you don't necessarily want. Sevelamer is basically a resin that binds the phosphorus in the GI tract and does not exchange it for any metal. There's no metal to absorb. It basically sucks up those phosphorus molecules and basically it goes out of the stool. The problem is that it also sucks up water. And as the sevelamer pills go down the GI tract, the resin becomes bigger and bigger. And that's why many patients feel bloated and they get constipation. So it's a terrific phosphate binder from a theoretical standpoint because it doesn't have a metal that can be absorbed, but it does have some tolerance issues in terms of bloating and constipation, which means that a lot of patients don't like to take it. So then we go back to the metals. There was lanthanum, which never really caught on in the United States. That's phosphenol, in case anybody out there is taking that. and the nice thing about lanthanum is it does bind phosphorus very, very well, but there's also the concern about, some of this metal is going to get into the body and what's it going to do over time. So I think because of the aluminum experience, a lot of nephrologists really didn't buy into it, including me. I really didn't think that it was a good idea to give people a metal that there is no minimum daily requirement for or no physiologic use for. So then people said, iron is something we can all use. We give patients on dialysis iron already because they have iron deficiency anemia because they're losing blood in the dialyzer circuit and oozing from their vascular access sites and vascular access surgery and phlebotomy for blood testing, etc. Most dialysis patients are iron deficient. So why not do a twofer? Give the patients a metal that's iron, and that will bind the phosphorus. And if some of that iron gets absorbed, no big deal, because the patients need iron anyway. And Eric even mentioned that was something that was well suited for him because he wanted a small, continuous dose of iron as opposed to the big IV doses that patients often get on dialysis. So iron seems to be a good thing. The only problem with Auryxia, which is iron citrate, is that a lot of patients will get diarrhea. But when used in combinations with sevelamer, those two will often balance out, and the patient might end up with, pretty regular bowels. Velphoro is a little different form of iron. It's bound to a matrix so that it's not absorbable. The iron molecules in the Velphoro will bind the phosphorus, and there's basically very little iron absorption, and the whole thing goes out in the stool. But as I said, one of the problems with Velphoro is it's a really big pill. It has to be chewed and then swallowed, and a lot of patients don't like that chalky feeling. So what's new on the horizon? These are all phosphate binders. There is a new form of phosphate lowering therapy that, rather than binding the phosphorus, just prevents the cells in the GI tract from absorbing the phosphorus. Okay. The sodium phosphate exchanger that is normally involved in phosphorus absorption from the GI tract is basically downregulated. So what ends up happening is the phosphorus goes out in the stool along with some salt, but that brings water with it, and that will often cause diarrhea like it does with Auryxia. But the nice thing is, because it's a completely different mechanism of action from phosphate binders, it's not working on binding the phosphorus. It just works on preventing the GI tract from absorbing the phosphorus. It works very well in conjunction with phosphate binders, especially in those patients who are almost at the goal. They've gotten their serum phosphorus down 2 or 3 points. They're pretty close to the goal line. Their phosphorus may be 6 or 7. Another gram per DL of phosphorus lowering will get them down to below 5.5. And often the addition of this new agent called tenapanor will be enough to get them to the point where their serum phosphorus is in the target range. Now, tenapanor is not yet approved by the FDA. There was a cardiorenal FDA drug advisory committee that met earlier this year that did, in fact, recommend approval of tenapanor. We're all expecting that it probably will be approved by the FDA sometime in the fall, and will probably be available for use in the United States sometime in the first quarter of 2024. But like the other oral agents that lower phosphorus, it will be included in the bundle. And since it's new and technologically advanced, it will be more expensive. And the likelihood that a dialysis provider will approve it as first-line therapy, I think, is very small.
So we just have a few minutes left, and I want to thank everybody, Jay, for giving us a great education on binders and phosphorus. This is something that's so important for all of us. I know after even 10 years, 20 years, we've all learned something tonight. Lauren, thank you for the background on how we get our medications paid for, and the importance right now, which is what's before us, of making sure that we use our voice. And if I leave you with one thought tonight, that is that you just stay with us. We will be providing you with the links for supporting the payment of keeping the bundle. Oral only out of the bundle, so we can continue to have this choice. And as these new drugs come on the market, we want to be able to use them, especially if none of the others are working for you. There's just so many things that need to happen here, and we're going to count on you to help us get that goal. We need to make sure that Congress hears us. We make sure that CMS hears us. And as I told you in the past, we've been successful at this. HDU has been incredibly powerful. They loved hearing from us, actually. So I'm here to tell you that we need that voice, and we're counting on you to help us. We've got a month here, and we're going to make sure that you have all the tools you need to let CMS know how important your choice is in your medications and your care. And expand on it in any which way you can. They will have to read every single comment. So I just want to thank everybody for coming tonight. It was such an important meeting. You can chat among yourselves. We leave the chat open for a while, so feel free to continue the chat. But we're going to sign off here. And again, thank you to our participants, Lauren, Jay, Dr. Wish, Eric, and Dawn are my staunch advocates. So thanks, everybody, and have a great evening. And I hope you enjoyed this.
Thanks. Good night, everyone.
Thank you.
Good night.